everybody. We're going to talk today about a healthcare and community provider integrated interprofessional team. And we want to also discuss a bit about how we use this as a virtual mentoring model as well. So I want to, let me put this in presentation mode. I just noticed I had it. Okay. So I want to also thank everybody who helped with this presentation. I have it listed there. And also to thank the GWEP grant for helping to make this team continue to be able to meet. So our objectives today is by the end of this presentation, you should be able to discuss the importance of social factors of health on healthcare outcomes, to describe the operations of the care management interdisciplinary team, to identify the types of recommendations that are made by our CEMENT team, which is how we usually say our care management interdisciplinary team, and explain advantages of using this integrated model to provide students as an avenue for a virtual mentoring model. All right, so when we talk about social determinants of health, according to the CDC, those are considered to be the conditions and the places where people live, learn, work, and play that affect a wide range of health risks and also health outcomes. And what we know is that our medical services that we provide, so our direct patient care medical services, really account for about 20% of healthcare outcomes, while the social determinants of health account for 80% of those outcomes. So what exactly are those social determinants of health? I have listed here just all of the influence on our healthcare outcomes, and they're organized by the percentage that they influence. So to start with, the social and economic factors, things such as education, employment, income, family support, social support, and community safety, those end up impacting about 40% of healthcare outcomes when they have looked at this in various studies. Health behaviors, things like tobacco use, diet and exercise, alcohol and drug use, and sexual activity influence about 30% of healthcare outcomes. The actual clinical care, as I discussed already, that includes access to care and the quality of care. Surprisingly to me, but really not surprisingly, influence only about 20% of healthcare outcomes. And then physical environment, things such as air and water quality, the availability and quality of housing and transit services, that actually influences about 10% of healthcare outcomes. So what we have tried to do with this care management interdisciplinary team is to mesh the medical part and those things that affect the social determinants of health. So we have a wide variety of members of this team that I'll discuss in a minute that really try to impact all of these areas. So to give you some idea of how the care management interdisciplinary team works is we have a care manager, and the place that we have started our care management, our CEMENT teams, are through the Area Agency on Aging or Direction Home, and in particular, the Akron Area Agency on Aging is where we originally had started this. And the care manager from the Area Agency on Aging visits the consumer and collects information about their care needs. The next step is that they present this information to the CEMENT team. And this information is formatted in a pretty standard way that they'll present to the team information about their living situation, their current diagnoses, their current medications, what their functional status is, any physical impairments they have, and they answer to questions of how does the consumer ambulate? Do they have any adaptive equipment? What mental impairments may they have? Have they had any hospitalizations in the last 3 months? And what is the care manager's primary area of concern about this patient to bring to the team? Our team then collaborates. Our team is made up of primarily social workers, nurses, pharmacists, geriatrician, and then students from all of these disciplines as well. And the reason why I have both of these previous slides is that we do meet basically virtually. We've had a couple different platforms that we use, but we do meet virtually. So after we meet and collaborate about what we can do for this patient, we do fill out a team communication form. I've changed things so you can't really recognize the patient, but this is an example of a communication form. We include in this the summary of pertinent information, what the problems and concerns are, the current diagnoses, the current DME service and services that the patient's getting, and then again, what the care manager concerns on. And then you can see through our recommendations that we have a mixture in these recommendations. I have the insomnia is listed on this first one, but we look at that was fairly heavy on medication type things that were going on that might be aggravating the patient's insomnia. You see why there we go. And then we also want to include those social determinant of health type of issues as well. Interesting thing was that this patient was very nervous about the fact that she has seizures. She lives alone. She's afraid she's going to have a seizure and no one will know about it. So connecting her up with a life alert that has a false notification, things with her weight loss, and then delivery services that she does have an issue that with mobility, but where she lived, they won't deliver to her apartment. They only deliver to the front desk. And that was a barrier for her. So really brainstorming on some issues that would help her be able to get her deliveries in a timely manner. All right, so in summary, I thought since I went through that fairly fast, is we have a care manager that basically prepares the summary to present to CEMENT. Then the CEMENT members collaborate to prepare a care plan for the patient. That CEMENT leader and the pharmacist write up a summary of recommendations that are then sent out and vetted by the nurse, the pharmacist, and the geriatrician to just make sure that everything is correct and we're all on the same page. And then that goes to the care manager to present to the patient, and also to the primary care physician, as well as to any specialists that may be involved that are pertinent for what we are recommending. Our CEMENT meetings are held weekly. As I said, they are right now, they're through Zoom. And we really do, these have become something that we have many students at, and we use to really model how a team practices. This became very helpful as COVID started and our students weren't able to attend some of the other interdisciplinary teams. So this provides a way that they can be involved in a virtual manner. Having a little trouble, there we go. All right, so I wanted to provide for you some ideas of what type of recommendations we are presenting for these patients. So this is a sampling of 80 patients that were seen over a 1 year's time. We had 19% of our patients did have recommendations for falls prevention. 71% had medication change recommendations. 61% had safety interventions, recommendations, and we had 24% with behavioral health type of recommendations. So from our team, some benefits that I feel that this team has is they do really set, like many interprofessional teams, they serve as an information source and a resource sharing source. So not only do we provide information to patients and caregivers that's very specific for the patients and caregiver situation, but I think that the care managers, as well as other team members and the primary care providers, certainly do benefit from hearing the team collaborate, and the information that is provided can then be also applied to other patients in similar types of situations. So that is one of the advantages of a team. And I think this team It is very much an integrated team where we have lots of interventions that are both medical and affect those social determinants of health. So I know that I, as a pharmacist, have learned a lot from attending the CEMENT teams, things that I hadn't learned in school, but things that are very helpful for patients. All right, some other benefits of the CEMENT as a virtual mentoring model. As I said, that we do have interprofessional students. We also have interprofessional residents that attend these teams. This, in my mind, serves as a very safe and accessible place for these students to practice actually working within a team. So I know that for my students, they are given the information ahead of time that is de-identified. And then as the meeting goes on, it serves as a place that they can practice presenting to the team. And then have all of the team members react to what they are recommending and provide some mentorship as far as if anything is not quite correct, that we can correct it right at that point. So I have had very positive feedback from the students, at least from my students, that they feel that this is a very helpful way for them to learn about how to be an interprofessional team member. I did also want to mention how we have expanded our CEMENT model. So first of all, we did spend approximately a year where we really mentored another area agency on aging, and that is the Cleveland Area Agency on Aging. So they presented a patient to us each week, to our team. And within the last, I would say it's probably been 6 to 9 months that they have really gone off and created their own team. So we do now have another CEMENT team at another area agency on aging in Cleveland. We also have, through the GWEP grant, we have provide the Geriatric Resource Course, or the GRC. And fairly recently, we have developed another similar CEMENT type team, very similar setup. We do have some expanded membership with more membership with specialties that do overlap the social determinants of health. And we also have providers, and Dr. Strader is here today. She has been one of our providers that joined the meeting. This is a little bit different of a model, and the fact that the PCP actually joins us. And that does actually make it a little bit, I think, better, because we get a little bit more information from that PCP. Rather than providing written recommendations, the recommendations are provided right at the meeting directly to the PCP. It also serves as a place where our GRC attendees can learn about interprofessional team as well. And then some of our GRC attendees, after they've graduated from the Geriatric Resource Course, will also bring their patients to the team as well. So it has several unique qualities, but really the model is still that CEMENT model. And then another area that the CEMENT has been involved with is a project through the Habitat for Humanity. So the Habitat for Humanity was able to get a grant that helps our patients who have issues with falling. And their grant actually helps to provide some home modifications to decrease the risk for falls. So as part of their activity, once the applicant is actually approved, then we also have the patient's information provided to us through the CEMENT process as well. So that allows us not to only improve their environment, but also to work on the other areas where that may be increasing their risk for falls as well. So that is everything I had to present today. So just a quick short presentation, and I'd be happy to answer any questions. I know some of you are actually part of this various cement teams that we're doing. So if you have any comments as well, that would be great.
Sue, I just wonder if you had an idea of the percentage of med changes. You said 71% had med change recommendations. Just wondered how many of that roughly were deprescribing?
Let's see. I am not sure why my screen went black, but I would say approximately 50% maybe are actually deprescribing. There's a lot of optimization, and that's kind of something that sometimes it's not only that they're on too many meds, but maybe that there's a better med to actually address a particular situation that they're having. But that would be something that would be interesting to look at. We also find quite a few patients that may have a particular condition that just is not quite being treated as well as it could be, and therefore causing them symptoms and issues. So I would say probably about 50%. So good question though.
Thank you.
Actually, the 4 cases that I presented so far, 3 of them, Dr. Fosnight make recommendation for deprescribing, and like all 3 of the 4 has medicine, like take off from the list, and dangerous medicine too.
I guess if you look at how many of our patients actually have deprescribing, I would say most of them do. So almost everybody has some deprescribing, but there's other recommendations as well. So if I was just looking at how many patients versus the percentage of my recommendations, it would probably be all patients or close. Not all, but close.
I think probably interesting from that standpoint of probably almost all, right? And I mean, when we're looking at our CMIT cases and obviously the cases that are brought, you know, they are like the most complex, right? They're the ones who have that interaction between those social determinants of health and those social factors and you know, complex medical situations where I always quote her on this one. One of our nurse practitioners is like, and they have a past medical history of everything, right? So I would say, yes, there's probably all of them that there's recommendations for deprescribing, but then there's also those recommendations for optimization, which sometimes means actually recommendations for initiating new medications as well, which sometimes, you know, may seem counterintuitive, and what our goals from geriatrics may sometimes come across as, but obviously optimizing those medications is critical, as well as then trying to get rid of ones that don't have an indication or potential harm.
Yeah, I definitely feel from the medication role that the term polypharmacy is kind of a misnomer, because over the years that's really kind of morphed into the idea that we need to optimize meds. So you can have somebody with 4 meds, but if they're the wrong meds, they're having problems with it. So trying to decrease adverse effects and decrease symptoms and optimize their ability to take care of their disease states is really what that has. And some have proposed that maybe we should call it malpharmacy instead of polypharmacy, because it's not always about the number, it's more about the quality, I suppose.
Right, like everybody, most people I think are probably familiar or have heard of the Beers criteria if you work with older adults, as far as, you know, the emphasizing more and more like the potentially inappropriate medications, because you also get that response of like, they're on this list, they can't be on them, and there's still reasons sometimes for people to be on these medicines. So the potentially inappropriate, with I think more I don't know, applicable or approachable the guidelines with the start/stop, right? So you're really looking at guidelines that are talking about this combination of things to optimize those meds.
It's such an important area to emphasize, is that, you know, the medications on the bears list are certainly things we need to think twice about, but there are some patients that it is appropriate to use those. So just not being such a computerized type of a review, but a more personalized review is what we like to do with these teams. And getting all these people together, and some that have had a lot of contact with the patient, is very helpful to make those determinations.
I have to say, from that standpoint, I've had that opportunity with our kind of traditional longstanding CMIT to see it on both ends, as both a kind of consultant geriatrician who's, we have a snippet of their medical record and their medical history in order to make these recommendations, and how challenging that is. Certainly, and then also, like, how do we relay those pieces of information back to the PCP and usable, or their specialists, psychiatrists, neurologists, cardiologists are all folks that we often recommend sending these recommendations to. But it is a really unique and I think great situation when case managers are, I think, generally unbeknownst to them, bringing patients that are my patients as a house calls doc in the community to the team as well, and really being able to really have that dialogue between the primary care, in the community, being able to access other records and kind of knowing that person from your standpoint, and then really seeing the other side of what other people and kind of the lens that people bring are seeing sometimes very differently. There's sometimes patients are presenting, either they are presenting themselves, or our lens that we are viewing them really does come across very differently, and trying to bridge the gap between those two things to optimize care can be challenging, but also, I mean, it's a lot of fun. So I think seeing it from both ends can be has been interesting.
Molly has a question. Molly, do you want to unmute and ask your question?
I'm sorry, I didn't understand that. I didn't hear the question. Can you say that again?
Oh, Molly is asking, how are patients selected for the discussion?
Okay. I still didn't hear it for some reason. It was, how are patients selected for this discussion? That's a very good question. So from what I understand, the way that our patients are selected is these are patients that are brought to the team are having all of our patients that are from the Area Agency on Aging for that traditional cement are patients that are getting services at home, but they actually qualify to be in a facility. So they bring patients to our team when things are happening that are threatening that ability. So they're having lots of admissions, they're having symptoms that are not controlled, they're falling a lot, there's something that's going on that basically would threaten the fact that they would be able to stay within their home.
Additionally, at least when it first started, there was sort of an assignment that to ensure that there would be cases at every CMIT meeting, the care managers were sort of assigned, this is your month or week or whatever to bring a case.